everybody. My name is Kenneth Prager, and I'm the Director of Clinical Ethics at Columbia University Medical Center. I'm a pulmonologist, and I'm going to speak today about the ethical challenges that were posed by COVID-19 during the surge, in particular during the period of mid-March to mid-May at Columbia in New York City. However, these issues are posed continuously as the pandemic continues. So I will be using the Columbia experience as a paradigm for some of the ethical challenges that are being faced by you right now and may well be faced by you in the future. I have no disclosures. I'm going to speak about policy options during the crisis standard of care situations during this pandemic. I'm going to also speak briefly about the New York State response to the COVID-19 surge in terms of legal issues. Then I'll turn to ethical issues with medical futility during the surge. Then the toll on physicians and nurses during the surge. And finally, experience of the Columbia Ethics Committee during the pandemic surge and lessons learned. The most basic question ethically during a situation like this facing physicians and hospitals: how can the most lives be saved? So the greatest ethical challenge during the COVID-19 pandemic surge and through any type of pandemic surge would be how to save the most lives when the demand for life support resources threatens to or actually does outpace supply. What are these resources? Well, the resources are either human or material. The human resources are obviously physicians, nurses, respiratory therapists, and others involved in the treatment of patients with COVID. The material resources, as you might well know, are ICU beds, potentially ventilators, dialysis machines and dialysate, medications, PPE, and COVID testing material. What are the options that are facing physicians and hospitals when this surge occurs, when the demand for resources outpaces supply? Well, there are basically four options. The first one would be to treat everybody on a first come, first served basis. The second option would be, no, we have to decide how to use our resources in the way most likely to save the most lives. Let us favor those most likely to survive over those less likely, regardless of their places in line. Or a third option would be not to have to make those decisions of triage, not to have to limit the number of patients with a first come, first served policy, but let us expand our ICU and our bed capacity to be able to accommodate all the patients who come to our facility. And finally, there's an option of transferring patients to another facility when our ability to accept those patients is limited. But that, of course, presupposes that there will be facilities that can accept the patients. Now, there are problems with each of these options, and let's look at them briefly. The problem with first come, first serve is very simply that it would result in the unnecessary loss of lives. Patients who could most benefit from the scarce resources will die because these resources would be used for patients with a hopeless prognosis who preceded them in line. This is clearly not the most effective way to deal with the excessive demand on our resources if our goal is to save the most number of lives. There's a problem with the triage policy as well. The triage will favor those most likely to, well, first of all, the principle justifying it would favor those most likely to survive over those less likely, regardless of their place in the line. It's a utilitarian philosophy, which basically says we must do the most good for the greatest number. So how accurate are we in prognostication is one of the questions that arise. In order to triage properly and ethically, we have to be able to know fairly certainly who is most likely to benefit from our resources. How accurate are our prognostication tools? Secondly, there is the threat of discrimination. There are people in underserved communities or people in communities that represent people with physical and mental disabilities who feel that they will be discriminated against if we are going to use a triage policy. And third is the moral distress of families and caregivers when life support is unilaterally withheld or withdrawn from families who are not consenting to the withholding or withdrawing of those resources, of the treatment. And in terms of the third possibility, namely that of expanding ICU capacity, there are issues there as well. By expanding our ICU capacity, for example, the quality of care may suffer. We are having to use people who are not adequately trained to be able to staff those beds. We don't have an unlimited number of intensivists and nurses to be able to treat these patients. And even the quality of the material resources may suffer. Secondly, there's the moral distress of the overextended providers. When a nurse has to care for 4 patients in an ICU instead of 2, that nurse will feel discomfort and moral distress at providing what she or he may feel is suboptimal care. And similarly, physicians who are not adequately trained in supervising these patients in the ICU may feel very uncomfortable and ethically compromised in being put in a position of responsibility where they do not feel fully capable of dealing with. And finally, there is, even in this circumstance, there's triage of a sort. When you open up your ICU beds and you expand the number of beds, who will go to the standard ICUs, which have the best people staffing them, and who will go to the ICUs that are felt to be suboptimal? Now, the ethical principles that are involved in the triage are as follows, and these are the typical principles that one sees in discussing issues of medical ethics. We talk about patient autonomy, and to respect patient autonomy, we want to respect patients' wishes regarding access to life-sustaining treatment. The question here is, must we obey the request to receive life support even when the patient has a very poor prognosis? Does autonomy trump our clinical judgment when we feel that this is an inappropriate use of critically short material resources? Must we obey the patient's autonomy in that circumstance? Then there's the principle of beneficence, which states that we should do the most good possible for our patients. Is the physician's obligation to do what is best for the patient, is that ever trumped by acting for the greater good of society? In order to save the most lives possible, is it ethical to limit the treatment that we will possibly provide to a patient for the greater good of saving more lives? A third principle is the principle of non-maleficence. First, do no harm. One can argue that withholding or withdrawing life support without the consent of the patient or the family is a major violation of this principle. And finally, the principle of justice, which argues for the fair allocation of scarce resources. Any triage policy must be vetted very carefully so that we are fair to all patients, regardless of their race, their ethnicity, their income, their immigration status, and their insurance status. I should point out that we actually have been practicing triage for many, many years in this situation of organ transplantation, where we routinely triage patients, and society has accepted this. We offer organs not to everybody because we don't have enough, and we decide on offering the organs to those who most likely will benefit from these organs. So we actually have been employing triage for decades in the situation of organ transplantation. Now, here are some of the basic features of these triage policies. There are many such policies, about 60 such policies across the country, and we have triage committees in these situations, and they decide who shall receive life support or have it withdrawn based on a scoring system. There are exclusion criteria, and the criterion that's used is what's called a SOFA score. In one of the criteria, that's the sequential organ failure assessment. The question is, how accurate is the SOFA score for prognosticating? And the SOFA score was actually formulated for deciding on triaging patients with other diseases. Is it equally applicable to the situation of COVID? And there are serious questions about that. Now, based on a SOFA score in these triage policies, you would place a patient in four categories, one of four categories, that the prognosis for survival is either too poor to justify the ventilator, or the status is too good and the patient doesn't need to be in an ICU, or a patient who has a favorable prognosis but would need the ICU and a ventilator, and a fourth category of sicker patients who have a less favorable prognosis but who may benefit from a ventilator. There are some of these policies also have exclusion criteria where the patient would be not given an ICU bed. Such an exclusion criteria might be somebody who is in immediate or near immediate risk of death, even with aggressive therapy, somebody with end-stage cardiac or pulmonary or neurologic disease where their death is imminent because of, for example, a multi-organ failure, etc. This patient would be in an exclusion criteria. These patients then would be given a trial of ICU treatment. They would be reassessed at regular intervals, and those patients who are improving would continue with ventilatory support in the ICU, but the patients who are not improving or deteriorating, the ventilator would be withdrawn if needed for a patient with a more favorable prognosis. The critically important but difficult, emotionally and ethically difficult decision of withholding or withdrawing a ventilator, this decision would not be made by the treating physician, whose obligation is to do the best for the patient in front of him or her. This is a decision which would be made by the triage committee that is based on the objective criteria that would be applied fairly to all patients. And a point that I would make is that withholding a ventilator and making a patient do not attempt resuscitation or do not attempt intubation, this is much easier emotionally for physicians and family than actually withdrawing the ventilator, withdrawing life support, turning off pressors in a patient whose life is being maintained on these interventions. Now, there are concerns with the triage policy. And as I mentioned before, the disability community has concerns in terms of discrimination. Patients with intellectual disability or dementia or severe physical disability, would these patients be discriminated against by virtue of their condition per se and without reference to the likelihood of their survivability? Is there an inherent bias that physicians would approach these patients? And there is a great deal of concern in the organizations that represent these individuals that they would be discriminated against. There are concerns also that age may play an inappropriate role in life support decisions in terms of years of life remaining after discharge, that although the patient may survive to hospital discharge, but a much older patient who has a shorter life expectancy than a younger patient perhaps should not be given the scarce resources. And there are concerns, therefore, for people who represent the aging community, that they would be discriminated against. And finally, would there be bias against people who have poorly treated medical conditions at the time of presentation to the emergency department? It would be felt that their prognosis is poor. They would not be given life support. However, their medical condition may be poor because they have had inadequate care. And so they would be discriminated against on the basis of the fact that they did not have access, did not have insurance, and so forth, and therefore would suffer inappropriately in a triage policy. One essential condition to implement the triage policy is that physicians have to be guaranteed legal protection. That is a very critical issue, and I'm going to turn to that in a moment in a little more detail. You need to have legal protection by legislative act or by administrative act by the executive branch of the government. Otherwise, physicians may be liable to malpractice suits. In addition, you need to have the public trust if the policy will be implemented. And I already mentioned about communities that are already concerned. Mistrust already exists in the disability and in minority communities. A triage policy has to be transparent. All people must be treated alike, as I mentioned before. And this must not be the policies of certain hospitals. It should be across the board. There are some controversial questions with regards to triage policies. Should patients who require more intense care be disadvantaged? Somebody, in the case of resource scarcity, should patients who are going to require shorter periods of intense care, should they be prioritized over patients who would be likely to occupy an ICU bed for much longer period? In addition, should patients who have a poor long-term prognosis, even after discharge from the hospital, should they be disadvantaged? And should physicians, nurses, and other healthcare providers be favored in allocations? Would that be considered inappropriate favoring of our own by drawing up a policy which would favor healthcare providers? And if we do favor them, in what way? And if we don't, how would this affect morale? And how would this be perceived by the public? Now, the issue of potential legal liability was addressed in an article in the Journal of the American Medical Association by Cohen et al. And they wrote that existing federal and state statutes, this is in the United States, of course, they provide only limited immunity to physicians and nurses in times of emergency. These laws do not immunize decisions to withhold or withdraw ventilators, which could be seen as willful, reckless, or wanton conduct, and thus beyond the scope of existing shields. And most importantly, a clinician who intentionally withdraws a ventilator from a non-consenting patient could conceivably be charged with criminal homicide. And so Cohen et al., they advocated that state legislatures should pass laws that would immunize all healthcare clinicians in these circumstances and immunize them from civil and criminal liability for ventilator triage decisions that are made in good faith compliance with mandatory or voluntary state-approved protocols. And without this immunization, it is highly unlikely that physicians would remove patients from life support or even withhold them from life support because of the fear of being sued. I would just proceed and say that in New York State, there was a law passed in April of 2020 during the height of the surge, and this was a legislative act that would grant qualified immunity to hospitals and physicians for acts and omissions that occurred from the beginning of the governor's emergency declaration through its expiration, and it covered liability stemming from the care of individuals with and without COVID-19. What did this immunity apply to? It applied to it did not apply to criminal misconduct, gross negligence, but it made clear that acts, omissions, and decisions resulting from a resource or staffing shortage would be covered. So this would actually apply to the physicians in a situation where the ICU care was expanded, where a large number of ICU beds were created, and it was felt that the quality of care might be not as good as prior to the pandemic. This is the kind of conduct that would be protected by this act, not an act, for example, of removing life support from a patient or an act of withholding life support against the wishes of the family. Only where the quality of care could be construed to suffer as a result of expanding the number of resources to accommodate these patients. Now, in fact, in New York and in most of the states of the United States, instead of implementing triage policies The hospitals in New York City greatly expanded their ICU and ventilator capacities and the number of ICU physicians and nurses to staff them. Operating rooms, cath labs, and open spaces were converted into ICUs. And to just give you an example, at our hospital, normally we have 117 ICU beds. At the peak, we had 300 beds in an ICU situation. Renal replacement therapy, normally about 15 patients at any given time. At the peak, we were servicing 60 patients. The nursing ratio was normally 1 nurse to 1 patient or 1 nurse to 2 patients, and at the peak it was 1 nurse to 4 patients very often. I'd like now to look at the issue of medical futility during the pandemic surge, and using scarce medical scarce material and human resources to give ICU treatment to hopelessly ill patients at the insistence of families was particularly distressing to physicians and nurses. Understandably, families that were faced with the sudden death of previously healthy relatives, they were extremely distraught. And this was compounded by the fact that visitation policies were such they could not be at the bedside of their loved ones when their loved ones were dying. So there was already an element of emotional distress and mistrust of what was happening in the hospitals. So on the one hand, you had distress felt by the physicians who sometimes felt that they were treating patients with no hope of survival and were using scarce resources because the wishes of the family were that it continue. On the other hand, the families were understandably wishing to have everything be done. They could not be there. Communication was impaired and so forth. Now, the moral distress of physicians who would have to continue life support for patients with no chance of survival, for families when the families wanted everything done, the physicians were concerned that they themselves would become infected while treating these patients. They felt that they would be prolonging the dying process of these patients instead of offering them a chance for cure. And they would use the scarce resources of, for example, ventilators and dialysis machines while treating these patients. And so the question is it ethical for physicians to be compelled to endanger themselves and use scarce resources while providing, for example, CPR to patients of no chance of survival? Aerosolizing the virus while providing chest compression, for example, or intubating these patients and increasing the likelihood of physicians and nurses becoming infected when physicians felt that there was zero chance that these patients would survive to discharge. So this took a toll on healthcare providers and physicians, nurses, and ancillary personnel. Although performing heroically, they were concerned. They were concerned about becoming infected, of spreading this to their family members, the need to physically be separated from their family during this time. And it was an enormous emotional toll of being unable to prevent large numbers of patients from dying alone. And this was most tragically represented by the suicide of one of the Columbia doctors, Dr. Lorna Breen, who committed suicide after recovering from COVID. She was the head of the emergency room at a Columbia affiliate, Allen Pavilion. She had no history of mental illness and appeared to succumb to the terrible emotional distress that she was put under during her time in the emergency room and also as a result of contracting COVID herself. There was a tremendously positive role of the palliative care during this period of time, during the surge at Columbia. The palliative care physicians helped in dealing with panicked and desperate families. They were used in the emergency department. They communicated with families by phone, by FaceTime, and they spared many patients the suffering of futile ICU treatment by enabling their families to come to grips with the imminent death of their loved ones and making them do not resuscitate. The ethics committee at Columbia University Medical Center experienced a quadrupling of the number of ethics consults during the surge when compared to a similar time period in 2019. In 2019, we had 25 consults during this period, and in 2020, 96 consults. 83% of these consults were for COVID patients, and I should note that at one point, 77% of the hospitalized patients at Columbia were COVID positive at the peak. And nephrology, the nephrology service also exhibited the incredible increase in need during this period. In the graph on the left, you see that in March the 24th, approximately 30% of the nephrology consults in the hospital were COVID patients, 70% non-COVID, and by April the 17th, approximately 90% of the nephrology consults were patients with COVID. And the graph on the right shows that in March the 24th, approximately 16 patients were undergoing dialysis, and by April the 14th, approximately 67 patients. This was an enormous expansion of the need for dialysis, and the red line showing the number of patients in the ICUs. This placed a tremendous strain on the nephrology service, and the issues facing the nephrologists when the demand for dialysis was greater than the potential supply of their resources. So they were faced with one of two options: either to spread the dialysis resources thin by providing what one would consider suboptimal dialysis to all comers, dialyzing somebody for 2 instead of 4 hours, for example, so that they could accommodate all patients, and they would have to accept, therefore, the consequences of some salvageable patients who might not survive for want of adequate dialysis, or triaging dialysis, withholding or withdrawing dialysis to some patients, and accepting the consequences of the patient and family objection to this. And there could be legal ramifications of this as well. Obviously, in these cases, each patient was dealt with on a case-by-case basis, but the nephrology staff was placed under tremendous strain during this period. And the issues that were facing them during the COVID surge, if withholding or withdrawing dialysis from hopelessly ill patient, if we were going to approach the families, you need to have unanimity of the physicians and the intensivists and so forth. This could not be a split decision. Only when there was complete unanimity. Communicating with the family was absolutely key to get their trust. The emotional effect on the physicians of suboptimal treatment was clearly an issue. And also physicians were learning on the run. This was a new disease, and we did not know all of the details that subsequently have come to light. And there were some survivors who were surprise survivors, people that were felt not to have much of a chance of survival. So all of this and the uncertainty plays an emotional trial. The role of the ethics consultant was critical during this period. We were able to clarify the ethical and legal issues for physicians. We assisted with goals of care, with communicating with families, with resolving conflicts, and with educating physicians and nurses with updated family hospital policy and the law. The lessons that were learned by the hospital was the ability to rapidly expand the ICU capacity, the partnership of clinicians and ethicists with hospital leadership regarding policies, legal support for new policies that had to be rolled out, and the enormous value of palliative care service. And of course, there will be societal issues that we have learned from. The need for advanced care planning, which was inadequate at the onset of the surge, the need to address issues that cause disproportionate effect on certain populations, on disadvantaged populations, certain racial populations, the need for broader hospital and community level discussions about non-beneficial care in general at the end of life, and the need to be better prepared for pandemics with storing PPE, ventilators, dialysis machines, etc. And I'd say the most important lesson learned was the response of the medical teams and the nursing teams to what was an incredible stress. the ability and willingness of doctors, nurses, and the entire healthcare system to rise heroically to the challenge of a once-in-a-century pandemic. Winston Churchill, paraphrasing his words at the time of the Battle of Britain during World War II, he said of the British people, this was their finest hour. I think we can apply the same phrase to the medical community during the COVID pandemic surge in New York City and what's going on even today in the US and across the world. Applying this to the medical community in general, we will say this was their finest hour. I thank you.